You wake up in a small Andean valley. The air is thin and cold. The mountains above you are quiet. Somewhere nearby, a small brown rodent moves through a grain shed. It leaves behind droppings. It moves on. That moment feels like nothing, but inside those droppings, a virus waits with perfect patience. It has been waiting in these mountains for thousands of years, and in 2026, something changed. Not suddenly, not with a headline, with a genome. Hantavirus is not a new disease. Most people in North America first encountered the name in 1993 during the Four Corners outbreak in the American Southwest. 33 people died. They were young and healthy. They had been exposed to deer mice, their lungs filled with fluid. They suffocated within days. The disease was named Hantavirus pulmonary syndrome, or HPS for short. Pulmonary means relating to the lungs. The syndrome is the collapse of the lungs' ability to exchange oxygen. Think of the lungs as a gas exchange system. Every breath pulls oxygen into tiny air sacs called alveoli. HPS floods those sacs with fluid. The exchange stops. The body starves of oxygen from the inside out. After 1993, public health agencies established a clear model. The CDC defined hantavirus as a rodent-to-human disease. You breathe in aerosolized viral particles, tiny dried fragments of infected urine, saliva, or feces suspended in air. You do not catch it from another person. The chain ends at the human. That boundary was considered firm. It was not firm. The Andes strain of hantavirus circulating in Argentina and Chile had been quietly breaking that rule for decades. Documented clusters showed something the rodent-only model could not explain. Caregivers fell ill, family members fell ill, healthcare workers treating HPS patients fell ill. The World Health Organization identified Andes virus as the only hantavirus strain confirmed to transmit between humans. For years, that confirmation was treated as a regional concern, a South American anomaly, a scientific footnote. In 2026, it is no longer a footnote. Before we go further, before today, did you know that one strain of hantavirus can spread directly between people? Drop your answer in the comments. I genuinely want to know what you think. What makes Andes virus different begins at the molecular level. All hantaviruses carry surface proteins called glycoproteins. These act as molecular keys. They fit into receptor locks on human cells, allowing the virus to enter the glycoprotein structure. Of Andes virus appears to attach to respiratory tissue with unusual efficiency. It replicates fast. It damages capillaries, the smallest blood vessels lining the inner walls of the lungs. When those capillaries fail, fluid pours into the air sacs. The lungs drown. What the CDC's Global Disease Detection Program and genomic researchers began tracking in 2023 was subtler and more alarming. The Andes virus genome was changing, not randomly. Accumulating mutations in the glycoprotein region, the region that governs cellular attachment, the region that determines how efficiently the virus moves between hosts. Researchers publishing in Nature Medicine flagged these findings with careful language. Science does not predict, but it identifies trajectories. And the trajectory of Andes virus in 2023, 2024, and now 2026 is one the scientific community is watching with focused concern. The question this video will answer is the one that sits at the center of that concern. If the only hantavirus strain that moves between humans is now expanding its range, accumulating mutations in its transmission-related proteins, and infecting populations with no approved vaccine and no approved treatment, what does that mean for what comes next? That is not a rhetorical question. The evidence has a real answer, and it begins in history. Go back to 1993. Not the laboratory. The land, the Four Corners region had experienced an unusual spring. Heavy snowfall, then warm rains, then a bloom of pion nuts, a critical food source for the deer mouse, Paromyscus maniculatus. The mouse population exploded. More mice meant more exposure. People cleaned sheds. They moved grain. They breathed. In what the mice had left behind, the CDC's investigation in 1993 was meticulous. Epidemiologists collected rodents across the region. They found the virus inside deer mice at rates as high as 30% in some locations. They named the strains in nombre Spanish for without a name. They established the transmission model, rodent-to-human, through aerosolized particles, in enclosed spaces with poor ventilation. 33 people died. The case fatality rate exceeded 50% among confirmed cases. The outbreak ended when mouse populations declined and human exposure dropped. The scientific lesson was clear, precise, and as it turned out, incomplete. 2 years later, in 1995, Argentina, a cluster of HPS cases in the Andes region of Patagonia produced a different pattern. The Pan American Health Organization began receiving reports. Patients were falling ill who had not been near rodents. They had been near other sick patients. Researchers documented the cluster with care. Their published language was cautious. They said person-to-person transmission could not be excluded. In science, that phrase carries the weight of an admission. By the early 2000s, multiple independent studies confirmed what the 1995 cluster implied. Andes virus transmitted between humans in close, prolonged contact, not through a handshake, not across a room, but through sustained exposure sharing a home with a sick family member, providing direct physical care without protection. A 2011 outbreak documented a 3-generation transmission chain. An infected person passed the virus to a caregiver, that caregiver passed it to a household contact. 3 links in a human chain, no rodent in the middle. The chain was real, the chain was documented, and the chain confirmed that the boundary the scientific world had drawn around Hantavirus in 1993 had never truly existed for Andes virus. If you want to stay ahead of stories like this one, the kind that matter before they reach the headlines, this channel covers them the moment they develop. Subscribing means you will not miss what comes next. No pressure, just an open invitation. The decades between 2000 and 2023 produced a fragmented picture. Outbreaks occurred in cycles. Rodent population booms followed unusual rainfall or food surplus events. Human cases followed the rodent spikes. Some clusters showed chains, some did not. Public health response improved. Protective equipment protocols for healthcare workers were introduced. PAHO maintained surveillance. Case fatality rates in clinical settings, with intensive care, improved modestly. Without intensive care, death rates remained above 35%. Then genomic sequencing arrived at scale. The same technology that tracked every mutation of SARS-CoV-2 in real time was applied to the Andes virus genome. Researchers began seeing what earlier, slower surveillance had missed. The genome was not static. It was accumulating mutations in the glycoprotein region, mutations that virologists identified as potentially relevant to transmission. Not certainties, signals, but in virology, signals in the glycoprotein of a pathogen with confirmed human-to-human spread are not dismissed. History is not a warning. History is a pattern, and this pattern is still running. Now comes the data that defines today, as of early 2026. The Pan American Health Organization has issued updated surveillance guidance for Andes hantavirus. The language is measured. PAHO does not use alarmist framing by institutional design. When an agency of that caliber issues new guidance, the scientific community takes that seriously. The guidance reflects a documented increase in case activity and a documented expansion of the geographic footprint of Andes virus across western Argentina and into southern Chile. The CDC's Global Disease Detection Program, which operates field epidemiology stations across South America, has tracked this expansion with precision. The primary reservoir host, the long-tailed pygmy rice rat, Oligorhizomus longicaudidus, is moving. Its range is shifting northward. This is not a random event. It follows documented changes in temperature and precipitation patterns across the Andean southern cone region. As the rodent's habitat shifts, the virus shifts with it. The CDC's field data shows Andes virus appearing in provinces where it had been rare or unrecorded within the past decade. In 2025, the World Health Organization placed Andes hantavirus on its priority pathogen list. Priority pathogen designation is not precautionary labeling, it is a resource allocation decision. It means WHO has determined that this specific pathogen carries sufficient pandemic risk characteristics to warrant accelerated research, investment, global surveillance coordination, and international preparedness planning. The characteristics that earned Andes virus that designation are documented and specific. Human-to-human transmission confirmed across multiple independent outbreaks. A case fatality rate that, without advanced clinical support, exceeds 35%. No approved vaccine, no approved antiviral treatment. Geographic expansion actively underway. Everything you are hearing is based on verified data from the World Health Organization, the Pan American Health Organization, the CDC's Global Disease Detection Program, and peer-reviewed research published in the Lancet Infectious Diseases and Nature Medicine. This video is made for awareness and education. It is not a prediction. That disaster will occur. Science deals in probabilities, not certainties. Our job here is to understand what the evidence actually says. Now follow the consequences. A person in a rural Andean community falls ill. The first 5 days are deceptive. Mild fever, deep muscle aches, fatigue, symptoms indistinguishable from influenza. Nothing says emergency. The person stays home. Family members are close. A spouse provides water and comfort. A parent sits beside the bed. An adult child stops by each morning. The virus is present. The exposure window is open. Between day 5 and day 10, the lungs begin to change. The virus attacks the capillaries lining the interior of the lung tissue. Thin-walled blood vessels begin to leak. Fluid pours into the alveoli, the air sacs where oxygen transfer occurs. The lungs become dense and wet. A clinical measurement called the oxygen saturation reading begins to drop. The body cannot compensate. Breathing becomes labored. Within hours, the progression can reach respiratory failure. The clinical term for this process is non-cardiogenic pulmonary edema. Non-cardiogenic means the heart is not failing, the lungs are. The fluid is not from cardiac pressure. It is from viral destruction of capillary integrity. This is why traditional treatment for fluid overload does not work. The mechanism is different. Management requires mechanical ventilation and intensive care. It requires equipment and specialists that do not exist in most of the rural Andean communities where Andes virus circulates. A 2024 study published in the Lancet Infectious Diseases analyzed household transmission data across documented Andes clusters in Argentina. The finding was unambiguous: infection rates among close household contacts of confirmed HPS patients were significantly higher than rodent exposure patterns alone could explain. Person-to-person transmission in household settings was driving cluster expansion, not a secondary effect, a primary driver. The second-order consequences radiate outward. Healthcare workers represent the next tier of risk. The WHO has documented occupationally acquired ANDV's hantavirus infections in medical staff providing direct care to HPS patients. This is not theoretical. These are verified cases. A pathogen that can infect caregivers creates a compounding pressure on health systems. It discourages treatment seeking. It depletes clinical capacity. It introduces fear into the facilities designed to contain fear. The regions most affected already operate healthcare systems under chronic resource strain. The economic consequences are measurable and immediate. Agricultural communities in Patagonia have documented suppressed productivity during outbreak periods. Informal movement restrictions follow cluster announcements. Tourism, a significant economic driver in Chilean and Argentine Andean regions, collapses when cluster news spreads. These effects fall hardest on communities with the least economic buffer. The pathogen does not only take lives, it takes livelihoods. The consequence that virologists do not speak about casually is the one defined by the word threshold. ANDV's virus is not currently efficient enough to sustain a large-scale epidemic outside tight household and healthcare contexts. It is not influenza, it is not measles, but it does not need to reach influenza's transmission efficiency to become a catastrophic global problem. It needs to cross a much lower threshold. A modest improvement in transmission efficiency, a shift in the glycoprotein that allows slightly more consistent spread through closer but less prolonged contact would change the calculus entirely. That is what the genomic data from 2023 and 2024 placed on the table. Not a certainty, a direction. And the critical window is now. The next 12 to 36 months of genomic surveillance will tell the scientific community whether the mutations accumulating in the ANDV's virus glycoprotein are converging toward increased transmissibility. Clinical cluster data will tell PAHO and the WHO whether the geographic expansion is accelerating or plateauing. Both signals are being watched. The question is whether they are being watched with sufficient resources. The honest answer to whether we are ready is this: partially and unevenly. The surveillance infrastructure that exists is real and capable. PAHO maintains active communication with national health ministries across Argentina, Chile, Bolivia, and Brazil. The WHO's Global Outbreak Alert and Response Network monitors hantavirus cluster reports in near real time. The CDC's Global Disease Detection Program deploys rapid response teams to investigate outbreaks. These systems have worked. They have identified clusters early. They have limited transmission chains through guidance and contact tracing. Their existence has saved lives. That is a factual statement, not reassurance. The gaps are equally factual. Rodent population monitoring the earliest possible signal of an approaching human outbreak is inconsistent. Across South America, in many of the rural provinces where ANDV's virus circulates, systematic rodent surveillance simply does not exist. A population boom among long-tailed pygmy rice rats, which reliably precedes human case surges, can go undetected for months. By the time the first human cases are confirmed, the exposure window has been open for weeks. The early warning system has a structural gap exactly where early warning matters most. Rapid diagnostic capacity for hantavirus in rural settings is limited. Laboratory infrastructure capable of confirming a hantavirus case quickly is concentrated in urban centers. A sick person in a remote Patagonian village may wait days for a confirmed diagnosis. Those days, the fever days, the muscle ache days, the days that look like the flu, are the most dangerous days for household transmission. Vaccine development for ANDV's hantavirus remains in early clinical stages. The National Institute of Allergy and Infectious Diseases in the United States has funded research into hantavirus vaccine candidates. No candidate has yet reached a Phase 3 clinical trial. Phase 3 is the stage that determines real-world efficacy. There is no approved protection, not for healthcare workers, not for rural communities in endemic zones, not for anyone. There is also no approved antiviral treatment. The only intervention that reliably changes outcomes is early access to intensive care, and in the communities carrying the highest burden, that access is the most constrained. Personal protective equipment protocols are now embedded in WHO and PAHO guidance for ANDV's hantavirus cases, specifically because of the confirmed person-to-person transmission risk. N95 respirators and gloves for caregivers and healthcare workers, eye protection for close contact. These protocols are sound. The supply chains behind them, in the regions that need them most, are not. What does this mean for an ordinary person following this story from anywhere in the world? If you live outside the South American Andean region, your direct personal risk from ANDV's hantavirus today is low. The virus is geographically concentrated. Its human-to-human transmission, while confirmed, is not yet the kind of sustained chain transmission that drives a global epidemic. This is not a reason for calm. It is a reason for informed and proportionate attention. Awareness changes outcomes in infectious disease. Communities that recognize the early symptoms of HPS as something other than ordinary flu will seek clinical care earlier. Earlier clinical care is the single most consistent predictor of HPS survival. More people reaching intensive care during the treatable window means meaningfully lower death rates. That is not a small effect. It is the difference between an outbreak that kills 1 in 3 and one that kills far fewer. For communities in endemic regions of Argentina and Chile, the rodent exposure precautions established after 1993 remain essential and effective. Seal food storage, ventilate enclosed spaces before cleaning them, wear appropriate protection when clearing spaces with signs of rodent activity. These are not extraordinary measures. They are low-cost behaviors that reduce the first link in the transmission chain. Fewer rodent-to-human infections mean fewer cases that could seed household human-to-human spread. For the global public health community, the message is one of resource alignment. Andes hantavirus currently receives attention proportional to its geographic footprint, a regional pathogen treated as a regional concern, but a pathogen with its specific profile: no vaccine, no antiviral, confirmed human-to-human transmission, documented genomic evolution toward the region governing spread warrants investment. Proportional to its actual risk trajectory, not its current case count, its direction. The natural world and the modern world are not two systems operating in parallel. They are one system. A rodent's range shifts because rainfall patterns change, because temperature gradients shift, because of forces reaching every continent. A virus moves with its host. A mutation accumulates over generations of replication. A genome changes over years, not centuries. The signals embedded in the Andes virus genome in 2025 are not unrelated tool and use patterns in Patagonia, or to the warming of Andean valleys, or to the movement of people through corridors that rodent populations now occupy in new ways. These are not separate facts. They are one fact expressed at different scales. What the evidence says in 2026 is not that a pandemic is coming. It says that the conditions enabling a more dangerous version of Andes hantavirus are present, documented, and moving in a specific direction. The window to act on that information is now, not because disaster is certain, because the cost of acting before a threshold is crossed is far lower than the cost of responding after it. Here is the question I will leave you with. If the only hantavirus strain capable of spreading between people is expanding its range right now, with no vaccine and no antiviral treatment in existence, what would you want your government to have done 6 months ago that it has not done yet? Not the official answer. Your real answer. Write it in the comments. I want to read every single one. This is natural disaster. We cover what the earth, the sky, and the science are telling us before the rest of the world catches up.